All right, Jess, I have to ask. When's the last time you saw a central line get access for something that, if you really think about it, didn't need a central line at all?
Today, probably an hour ago.
Right. Yeah, it's everywhere. Labs, meds, the easy blood culture, just because the line's sitting there.
It's literally the path of least resistance. No needle stick.
Yeah, which is exactly the problem, because every one of those accesses is a tiny crack in the door for CLABSI. And today's article puts some real numbers behind something that a lot of us have felt in our gut for years. And the convenience of the CVC is quietly working against us.
Yeah, I really like this one. It's a scoping review, so it's pulling together evidence rather than presenting one study. And it gave me a few, okay, that's higher than I expected moments.
Same, yeah. And we've got two guests joining us today who are deeply embedded in this work. So first is Dr. Karen Brust. She's the hospital epidemiologist at University of Iowa Healthcare, did her training and spent years as ID staff and IPC medical director at Baylor Scott and White in Temple, Texas, before heading to Iowa in 2022.
And alongside her, Mary Beth Hovda Davis, a pediatric nurse scholar with 20 years in pediatrics and vascular access. Her work focuses on caregiver engagement for medically complex kids at home and improving outcomes for hospitalized pediatric patients. So she brings both the bedside and the research lens to this.
Yes, such a great pairing for this topic. We've got the epidemiology side and the vascular access side together. Dr. Brust, Mary Beth, welcome to the show.
We're really glad to have you both here with us.
Thank you.
Thank you for having us.
So let's set the stage. The article is called Limiting Central Venous Catheter Access for Blood Sampling and Its Impact on Central Line-Associated Bloodstream Infection. And it's a scoping review, meaning the goal was to map out what's already known rather than test something new.
Yeah, they followed the, and correct me if I pronounce this wrong, the ARCSI and O'Malley framework and Prisma SCR guidelines. They searched the Cynol, Embase, PubMed, Scopus, started with a stunning 758 records.
Whoa. And whittled that down to 6 studies that actually fit, which on one hand sounds small, but on the other hand kind of tells you that this is an underexplored area.
Yeah, it really, really is. And the 6 studies that made it through weren't tiny either. The settings ranged from a 20-bed cardiovascular ICU all the way up to a 700-bed hospital, adult and pediatric populations, including some pretty vulnerable groups like pediatric oncology patients.
The headline number for me was from one of the pediatric studies. Each additional CVC access per day was associated with a 0.7% increased risk of CLABSI in the following 3 days. That sounds small until you think about how many accesses happen per shift.
Yeah, which the review also tells us. So 7 to 8.5 times per shift in an adult ICUs at one academic center. So that 0.7% adds up fast.
And here's the kicker that I think a lot of bedside staff don't realize. In one study, 76% of medications given through a CVC could have been given peripherally. That's a big gap.
Yeah, it is. And the review landed on 3 interventions that actually moved the needle. Standardizing the time of day labs are drawn from a CVC, using phlebotomy teams for blood cultures via venipuncture instead of the line, and just, not using the CVC for routine blood draws at all when it's avoidable.
And the results weren't subtle. One study saw CLABSI standardized infection ratio drop from 1.31 to 0.66. Another saw their CLABSI count go from 9 down to 0 after bringing in phlebotomists.
0? That'll make you want to call your lab director ASAP.
Right after this recording, probably.
Yeah, so let's translate this for the folks on the floor. Dr. Brust, Mary Beth, if a bedside nurse is listening to this and they're thinking, but the central line is right there, why wouldn't I use it? What would you want them to understand? And Dr. Brust, I'm going to let you take this first.
First of all, thank you for having us. I think it's an important topic to discuss. So this is an important question, right? I want the bedside nurse to understand the outcomes of this entire project, which was every access of the central line comes with the risk of an introduction of infection into the bloodstream. So really it was this very question that sent Mary Beth and I on this quest to answer it. I'm a huge believer that all healthcare workers really want to do the best for our patient. And so a project like this, for me, helps define the why and that explanation at the bedside behind the importance of respecting the central line and avoiding overaccessing.
And building on that, for someone who isn't an IP, can you explain in plain terms how drawing blood from a central line actually increases infection risk? Like, what's physically happening that makes it different from a regular IV stick?
Good question.
I think it's easiest if you think of a central line like a highway that goes straight into the bloodstream. And every single time we access it, we're opening up that system. Now, we know we have mechanisms in place like scrubbing the hub, connecting the devices in order to draw the blood, but each of those steps is a different opportunity for microorganisms to get into the bloodstream. Even with perfect sterile technique and optimal flushing practices, it's really difficult to eliminate that microscopic contamination entirely. And over time, that repeated access can also contribute to biofilm formation, which is where the bacteria is essentially stuck in that plastic environment that's in the body, and it becomes a lot harder to get rid of. So the key difference is that when you're doing a peripheral stick, or a peripheral blood draw, it's a one and done. You cleanse the skin, a sterile device goes into the bloodstream, you draw the blood, and you're done, as opposed to the central line being repeatedly used throughout the period of time that you're drawing the blood and going directly into central circulation. So it's really not about how we access the line. There's been a lot of evidence and studies on how best to do that. It's really about how often we're accessing it that increases that infection risk. And that's what our review found, is that the frequent central line access was associated with the higher CLABSI risk.
I like how you're coming at it from a different angle.
Yeah. And well, I had a question because having a dedicated phlebotomy team seems to be one of the biggest levers in the review. So if a hospital doesn't have a dedicated phlebotomy team, is there like a starter intervention that's realistic, maybe for a smaller facility to try first?
Absolutely. Honestly, this was an important aspect, even in our story here, where we had a pretty robust phlebotomy team to start with. So I'm going to go ahead and very briefly tell you this story. I met with the nurse manager on our bone marrow transplant unit on the adult side. Obviously, a highly vulnerable population, high usage of central lines, and at risk of CLABSI just at baseline. And so she was really open to having this discussion with me about all these entrances into the central line. And so what she did is actually put together a very manual process where they actually ticked a piece of paper every time they access the line. And what she was able to do there is show her unit's nurses how often they were entering the central line per shift. And then they themselves decided that they were going to change something on that unit. And so they've since moved to batching line entrances. So this, I would say, would fall under the category in the paper that we described as standardizing times to access the central line. So this was done specifically at one hospital where they, just kind of set certain times to enter the central line. So I would encourage anybody that's listening to this that maybe doesn't have a robust phlebotomy team to consider doing this as a first step.
That's a really cool idea. It's great to see some of these things that can come out of a study like this that can help people that maybe don't have those larger resources or teams. But let's get into the weeds a bit. The review found that only 2 of the 6 studies reported precision around their results, and several didn't fully account for confounders. As IPs trying to use this evidence to push for policy change, how should we be weighing studies with these kinds of limitations?
I think Mary Beth is going to talk a little bit more about this, but I'm just going to say that for IPC, this is not that unusual for us, right? So we're kind of used to sensing a positive signal, whether it be from the literature or not, going back to our teams and discussing what little small test of change we might be able to put into practice Then we pilot with the unit, and then we just start our PDSA cycles, and we shift and change and move through these quality improvement type projects to try to achieve quality outcomes.
What I like about that response, Dr. Brust, is that I feel like, and Nicki, I don't know if this is an observation that you've made as we've talked to researchers throughout our time doing the podcast, is that it's not always a one size fits all. So I love the concept of doing the small tests of change, because I don't think things necessarily are always going to work for one hospital like they do for another, or one unit like they do for another. So I think it is important to go through those steps of just identifying like what potential tests of change can we try, and how could they improve the quality after doing them. So I just think that's a great opportunity.
Agreed. That's why I was asking about hospitals that didn't have a dedicated phlebotomy team, because that can be difficult. And I wanted to talk about something else that stood out methodologically. So most of these were single site, retrospective, or quality improvement projects rather than randomized trials. And a lot of the interventions were bundled together. So how do you separate out what's actually driving the CLABSI reduction when, say, like the phlebotomy team, say that rollout happens alongside education and along with updated maintenance protocols?
Yeah, I think that's a challenge with any real world quality improvement, is that interventions rarely happen in isolation. In the studies we reviewed, things like phlebotomy teams, education, and policy changes were often introduced together, so it is difficult to tease out what the most effective strategy was. But instead of trying to isolate just one single magic bullet, I think it's more useful to focus on what's the shared mechanism across all of those interventions that were impactful. And then they all reduced how often the central line was accessed. So taking that as like your key cornerstone and what you're going to move forward is important. So whether it's batching labs, using peripheral draws, or having some type of dedicated team. I mean, this gets into the world of vascular access teams, for example, as well. They're all targeting the same thing, which is the interaction frequency of the central line. So with that being the strong conceptual takeaway, even if the individual components are bundled together, and as a highlight, it's important to note that when you identify a concern and raise awareness around it, that can be an intervention of itself, like all of these studies showed. It's also where evidence-based practice improvement frameworks can help you isolate which outcomes are. So for this project, we use the Iowa model, which is a well-known evidence-based practice framework, and also implementation science can also play a role in identifying which strategies are leading to the outcomes we're looking for. That would be areas for future study.
Fantastic. We'll look forward to hearing about them, right, Nicki?
I think we have another episode in the making.
So let's talk about vulnerable populations like our pediatric patients, people with difficult venous access. The review acknowledges complete CVC restriction isn't always feasible. I think we all know that, right? Are there specific decision algorithms or criteria that you'd direct IPs toward for figuring out when CVC access for blood draws is genuinely necessary versus just convenient?
As a pediatric nurse by trade and then specializing in vascular access, I'm fully aware that there isn't a one-size-fits-all situation when you're making these choices. There are patients where central line access for blood draws would be very appropriate. So any patient with extreme difficult peripheral access, history of vessel depletion, so you need to save vessels, like chronic kidney disease patients, neonates, and children with limited access who have lifelong vascular access needs. So that pulls in your whole pediatric intestinal failure population, or patients that just require frequent high volume or specialized labs. All of these patient groups may need other solutions, but you still need to take those facts into consideration. And so if you're developing a decision-making framework, which one of our studies did have a nice algorithm, the Curacao study had a framework that you could modify. But one, you should ask, can a peripheral draw be obtained safely and reasonably? Two, will using the central line meaningfully change this patient comfort or outcomes? And 3, is this test necessary right now or at all? And I think that question is a question that isn't asked often enough. And so if the answer to the first question is yes, that's usually going to be your safest route. But for vulnerable populations, I think it's also important to include the patient and their advocate, so a caregiver or a family member, as part of that conversation instead of making a choice for them. So if you educate the patient and family on the risks of multiple accesses from the central line, they may advocate for a different choice. And whatever decision-making framework goes into place, you just want to make sure the exception to the framework doesn't become the rule, and that practice would slip back to defaulting to the central device for all blood draws. And that's where it becomes less about convenience and more about clinical necessity versus that cumulative risk for infection.
Right. It's kind of like everything. It's patient-centered, it's patient individualized, and the thing that I keep coming back to is that this review essentially kind of reframes that central venous access itself as a modifiable risk factor. So it's not just line maintenance, it's not just insertion technique, it's the sheer frequency of touching the line. And that is a different mental model than a lot of the CLABSI prevention bundles that we operate under. So what's your take on how this should shift the way we think about CLABSI prevention?
Yeah, I've had the pleasure, I guess I will say it, but I started working on CLABSI prevention back when we first started publicly reporting it in 2009 at our institution. So that's a long, I'm afraid to admit how long that actually is. But one of the most important shifts from this review is that traditionally in all that time, our focus has been on insertion and maintenance, like very well-structured bundle elements required to be implemented, which includes sterile technique, dressing changes, things like that. But what this adds is that concept that the access itself is a risk factor, and not just how, but how often. So instead of thinking about how do we keep the line clean, it's just that shift of how often are we using it at all. And minimizing access to central line has standardly been a recommendation, but there's been no identified strategies of how you implement that. And this review gives you some interventions that you could already think about. So that shifts CLABSI prevention from just a technical compliance to really that behavioral and system level decisions, like lab ordering practices and workflow design, to structure more of a limiting than just an awareness of one.
Also, let's talk a little bit about diagnostic stewardship. The review points out that up to 56% of lab testing doesn't actually change clinical management. We talk about this a lot, actually. It's really interesting. And reducing CBC access for blood draws is almost a backdoor way into that conversation. Do you see this as primarily an infection prevention issue, or is it really a broader stewardship issue that IP happens to have a stake in?
You're welcome to disagree with me, but I'm thinking this is a broader stewardship issue. So I'm going to talk about a couple of things that I think are pertinent here. So the first is really routine lab testing. So the Choosing Wisely campaign has already alerted physicians about the overuse of lab testing and procedure. So I think most physicians like myself, we're pretty good at asking ourselves, is this CAT scan that I'm about to order, is it going to change my management of the patient? But mentally, I don't think that we're making those connections with routine lab draws on a daily basis. And then the second side of this in terms of diagnostic stewardship pertains more to blood cultures. So here, I think there's actually a little bit more motion in this particular area. And I think it was precipitated by the lack of physical blood cultures that hospitals were able to obtain after Hurricane Helene devastated our supply chains in 2024. So I will make note, maybe we can get them the articles from Dr. Faber and Dr. Seidelman. They came out with some excellent algorithms for blood culture practices. Here at the University of Iowa, we've been operationalizing some of these guidance documents. Again, we're starting with small tests of change in our intensive care units and then spreading from there. And so slowly, the diagnostic stewardship efforts, specifically as it relates to blood culturing practices, are improving. In general, I think these efforts benefit the patient, not just our infection prevention related metrics.
Yeah. I don't disagree with that at all. I think it is a broader application. And I really just want to say, I think this is such a great conversation because I think a lot of us know that central venous access overuse is a problem, but seeing it laid out with the actual numbers it's motivating.
Agreed. And for our listeners, the full review is a great one to bring to your next IP committee meeting.
Mm-hmm.
The intervention summary table alone could practically serve as a discussion guide.
So, just copy and paste the link to the podcast into your IP meeting, your committee meeting, and let it roll, right?
That's what I do.
Dr. Brust and Mary Beth's voice will be amplified at your next meeting. Thank you both so much for joining us today.
And to wrap up, I think the moral of the story is pretty clear. If your central line could talk, it would probably ask for a day off.
Yeah, or at least a standardized lab draw schedule.
We agree. That's great. Thank you for having us.
Thank you so
All right,
much.
guys. Yes, thank you for being here. And that is a wrap.
Thank you for joining us today. We are Nicki Shore and Jessie Swain, and this is the American Journal of Infection Control podcast, Science into Practice. Thanks for listening and doing your part to prevent infection, because remember, infection prevention is everybody's business.
AJIC Science into Practice is created by the Association for Professionals in Infection Control and Epidemiology with input from the APIC Center of Research, Practice, and Innovation, and Jean Brandt at AJIC and APIC staff, Rebecca Bartles, Ria Gupta, and Bobby Gulshan. We work in partnership with Human Factor and audio techs Blake Alton and Carolyn Schneer. To hear other AJIC episodes and to access information about this podcast and the field of infection prevention and control, go to our website, ajicscienceintopractice.org. That's AJIC scienceintopractice.org.